So what I'm going to do is I'm going to tell you a bit about my approach and general some principles, how I see these things, and it probably might be easier and help you in your practice some of these things. So what I'm trying to do is I'm trying to look at the components of the problem, and we will not be talking about diabetic feet because there'll be an afternoon, we'll have a chat about that. I'll give you my approach because my practice is principally adults. So I'm going to just tell you about how I deal with the adult foot and ankle problems, and I'll try to divide it into sort of some small components and see if that's helpful. Because if you look at, let's say, equine virus, it's like it's very complicated. So what my approach is try to divide the problem into smaller problems. So I think the most important from an adult perspective, how I see is the foot tripod is probably the most important thing. Is there there's a normal tripod or not? That's one of the issues. So if you divide this problem, as I said, let's say equine virus, where the problem is. If we divide where the problem is, that might help us to solve the problem. So as Om showed in the morning, so I see them in sort of, again, as segments. So if you see at ankle, you get equinus principally, right? And then what happens is that you get a subtalar where you get principally valgus, varus. Your talus can move a little bit in ankle, but principally it's a subtalar problem. And then you have a midfoot rocker, or you can have a midfoot caver. So these are the principal 4 problems we deal with the adult foot and ankle generally, right? And so if we have a problem, we need to see where they are. And there's a lot of problems which are interrelated. So like a hindfoot varus and the plantar flexion of the first ray. So that has interrelated, and we need to eliminate that. And the other thing which Om has also mentioned is very critical, the compensatory deformities. Where is the compensation in the foot? And is the compensation fixed or is it mobile? And apart from that, you have to examine properly and do all that. So I'm not going to go into that. So let's see, when you decide to operate, we need to decide, can I tackle all the problems in a single stage, or I need a 2-stage problem, right? And that will depend on a number of things. Is infection, all of the things, and the deformity was the problem, and what are you trying to achieve? It's too complex. You might say, look, I do this. There might be some compensatory secondary effects, and I'll come back and do some things later on, like, for example, plantar flexion with first ray. It looks unmobile, but you say, I don't know whether it will compensate fully or not. Let's correct this. If it's not a problem, we'll come back and do that. Similar kind of things. The outcome is simple. You need a plantigrade foot, hopefully pain-free, which you can wear normalish shoes. And when I say normalish, means off-the-shelf shoes with some insoles. We don't expect a normal, what we wear day to day for these patients to wear shoes, because that's not always possible for them. X-rays are totally irrelevant. It doesn't matter what X-ray shows. As long as the foot is in the right position, that is the important thing. So let's come back to tripod again. So if the tripod is normal, so I had this patient working in my hospital, actually, in orthopedics theaters, and he had a severe problem, number of surgeries in the past, and his principal problem was, I want to retire and with my full pension. So the idea was, he got a lot of problem with the lateral border of the foot, and all the simplest thing is just do a supramalleolar osteotomy, correct it, and offload his lateral border. So what happens in the foot is totally irrelevant. What X-ray looks totally irrelevant. He's pain-free, and he managed to work and retire normally. So the aim was simple, to correct the pain so he can work, right? Now let's look at the problem where, in this case, so if you see, it looks quite problematic. If you look at the first ray, how down it is, and apart from that, his foot actually doesn't look too bad if you examine. Apart from the first ray plantar flexion, the rest of the foot doesn't look too bad. So the question is, this is the other deformity, the hindfoot varus on all of the problems. Now, if you look at it, can I get a normal tripod? Can I reconstruct the tripod where I can do supramalleolar osteotomy? Yeah, possibly, yes. So, right? If you can do it, then you can do supramalleolar osteotomy. And if you can't, then you have to go back and see, you have to separate the midfoot from hindfoot to ankle. And then what you do is, you do a differential corrections. So in this case, we just fuse the toe, and then did a dorsal closing wedge osteotomy, and which gave us a reasonably normal tripod in theater, so which we expected kind of thing. And then we went again and did the supramalleolar osteotomy. And in this case, so and this is Anish, show these some images to Alvin how we take this picture. So this is here you see this is a tibia, this is your heel. It's not exactly a valgus, but it's sort of reasonable, and it clinically looked fine. So we stopped there and then what we did was, these are the final pictures, and this is the X-ray pre-op, and this is the X-ray post-op. So if you look at it, our plant reflection is of the first ray is reconstructed. And overall, clinically, she looks fine, and she has become quite painful, quite happy, and because her pain is gone. So we are not looking for a normal shape of the foot and give them a sort of a wonderful looking foot. The idea is pain-free plantigrade foot. That is the aim. So my take-home message for these things are that if you can reconstruct the foot to a normal tripod, do a simplest thing. And we don't have to do anything complicated. Foot is complicated enough anyway. So for the simplest means, what we can do, we have to do that. So let's do another patient. He's a 77, fit and well, no other issues, the multiple problems, hindfoot varus, and a few other things as they come along together. So here, so this is the patient, what we did, this is a clinical picture, and if you look at it, the problem is principally more or less the same. They walk on the lateral border of the foot, and is the excessive weight bearing where they do that. So this is the problem. So I've broken down the problem at which joint the problems are. Ankle, hindfoot, and the midfoot. And then we can tackle them separately, and how we do that, we'll look into that. So this is the preoperative plan. We do all this extensively, right? And during surgery, we did TL lengthening, improved the equinus, quite improved the varus, and remaining was done by the subtalar joint. And then we got a reasonable picture in the theater. So we just put a simple plaster because clinically the foot was looking fine, right? And again, this is the picture at 1 year when he was discharged, reasonably happy, pain-free. So again, what I would suggest is break down the problems, complex problem into simple problems, do a staged surgery, and when you get your desired result, stop, right? Because often you will find that less is more in foot. Don't try to do too much. So there's on-table X-rays we took and looked fine. And here, but the problem was we could not correct, the midfoot problem is separate. So you have to do a separate correct in the midfoot to give it plantigrade foot. So we put in a butt frame, and should have a pictures, yes. So these are final pictures with a reasonable looking foot. I'm only showing these X-rays because X-rays are looking good. If the X-ray is not looking good, I don't show them because it doesn't matter. If they're looking good, I'm happy to show them, right? So this is a good looking X-ray, so I thought I can share with you. And this is the clinical picture. So this is slight valgus, quite happy. And again, they don't walk miles. They're not going to sprint. The idea is to have a foot where they can walk reasonably pain-free with some normalist shoes. That's the plan. So take one-step surgery, starting from where the problem is, correcting gradually. If you need a multi-level correction, this is fine. But the important thing is the X-rays are not important. The clinically how foot looks, that's important. How do I approach this problem as a whole? So I identify the problem, where the problem is, then I identify the site of the problem, and then I see what I can do at soft tissue, osteotomy, whatever. And then I put an implant. Which implant is best, I think, for this patient, internal or external. So the other thing I would say, my take-home message would be for you is, don't be a slave to implant. That I'm a framer, I'm an internal fixation. No. We should look for that what implant gives the best result to this patient and achieve your desired outcome. Sometimes screws, sometimes plates, sometimes frame, doesn't matter. What we need to do is, what can give you the desired results. So if it's an ankle, I'm happy to do internal fixation if there's no infection, ankle fusions or osteotomies. If it's an infection, I'll always do external. Hind foot, my preferred is internal, even if an infection, if I can work around it. But rarely I put a mitral frames. They're not good. I mean, they're nice to put on, but it's hard for patient and everybody else, not the best frames. So internal is best done for the hind foot. In the midfoot, butt frame is amazing. Absolutely wonderful. It corrects everything, but you can do it in the internal. You don't have to have a butt frame. This is my preferred because I think you can correct all the deformities, adduction, plantar flexion, KVS, rocker, rotation, whatever you want to do, can correct beautifully with the butt frame, simple frame, and this is what I like and tend to do. If it's a lengthening, you can do a nail, you can do a frame, doesn't really matter. It's entirely your choice. So ideal outcome, I go back again, is this. You have a clinically plantar foot, no pain or minimal, ignore x-rays. They're not relevant. They're looking awful, doesn't matter. Ignore them. So to summarize, I would say that if you have a complex problem, break down into simple problems, see where the problems are, how you can correct it, what effect that correction will have on the subsequent deformities, right? And then plan your correction, right? And the other thing is that, do we need to go everything one stage? No, we don't have to. We can tell the patient, I'm going to do is one stage. If there's a problem, I'll come back and do a second stage. It's not an issue. Detailed examination, as pointed out in the morning, is very, very important. And see what are the deformities. Identify every single deformity. You may not want to correct it. You may not able to correct it in one stage, in which case you do two stage, otherwise do a one stage. Thank you very much.
Yeah, great lecture. Would you consider a supramalleolar osteotomy for a midfoot driven?
Sorry, osteotomy for?
For a midfoot driven supination of the foot.
So, yes. If it is a problem, if clinically it's a problem, so if the supination is a clinically problem, then yes. So the idea would be that can they walk reasonably? If they can't, then the aim is to make them walk normal. And the distance is not an issue. Somebody wants to go to the shop, somebody wants to go to the garden. So their functional needs to be assessed. And if supination is a problem, yes, I will.
Do you think that affects the ankle alignment significantly? I mean, because you will end up...
What supination does is, they start to walking on the lateral border of the foot. And then what happens is they start getting callosities on the lateral border, start having problems. Then TA starts pulling from inside. They slowly may develop varus of the hind foot. So it can be a progressive problem. It also depends on if what is the initiating process. Is it trauma or is it neuromuscular conditions? So that can also affect that.